Hello, everyone, and welcome to another nutritional medicine update. Thank you for joining me today. So this is another very important webinar topic for us to get updated on, reducing high blood pressure naturally. So let's roll up our sleeves and go to work. So around the world, up until recently, about 25% of the world's population really had blood pressure in the range that would be considered hypertension or high blood pressure. That actually has crept up, as you're going to see, to 30% of the world's population. As sodium intake increases in developed countries, you see blood pressure rising, as well as sort of people who are becoming more overweight and less physically active. But 75% of people that have high blood pressure have blood pressure that's elevated, but it's in the mild range, between 140 over 90 and 159 over 99. And studies show that non-pharmacologic interventions, diet, supplementation, and exercise, in a high percentage of these cases can bring that blood pressure down into the normal range. And this often is something that doesn't get factored into that medical consultation. That's why it's important for us to be armed with the evidence-based nutrition and lifestyle strategies to help patients lower their blood pressure. Whether they're on medication or not, these strategies definitely apply. And up to 95% of people that have high blood pressure, it's considered primary hypertension or sort of idiopathic. But really what that means today is that it's multifactorial. There's sort of a gene environment interaction that is part of the etiology. So we don't fully understand all these moving parts, but you're going to see some big pieces today. But hypertension is the most common preventable risk factor for cardiovascular disease. It's the one thing that if we could change that, you really change the clinical picture, reducing risk of coronary artery disease and heart failure and stroke and heart attacks, atrial fibrillation, peripheral vascular disease, even chronic kidney disease and cognitive impairment were linked to high blood pressure as well. So high blood pressure is the leading single contributor to all-cause death and disability worldwide. So, if you are a complementary health practitioner, probably after you graduated for the first few years, you were taking blood pressure in all your new patients coming into the office. It's part of your routine workup. And then slowly as the years go by, some of these procedures sometimes they drop off as you become more focused on the person's chief complaint, whether it's musculoskeletal or something else. But that blood pressure cuff that you have is a very important piece of assessment equipment. And hopefully this webinar today will, if you drop that procedure from your routine, you'll bring it back in. And I think ideally you want to get sort of a automated blood pressure cuff system for your office. They're more reliable actually. And, it saves you the time it takes less time to actually do the blood pressure. But I think doing it on the first visit and helping your patients who have a history of blood pressure monitor it to some degree is something that they do greatly appreciate. So beginning as low as, 115 over 75 millimeters of mercury, as blood pressure rises, the risk of a cardiovascular event also increases. Now, what they're saying is that you have to understand that whole white coat syndrome. So if they put a blood pressure monitoring system on you for 24 hours and you go about your regular business, once you get moving around and doing things, you kind of forget it's even monitoring you. So in a situation like that, at 24-hour ambulatory blood pressure, as long as it's under 130 over 80, everybody seems to be fairly happy with that. If you have a home monitoring device, the fact that you're taking your own blood pressure, your sympathetic nervous system discharges. There's a bit of anxiety sometimes. So they allow 135 to 85 to be still relatively in the normal range because they sort of know that most people are going to have a bit of a sympathetic nervous system reaction that will elevate their blood pressure slightly when they're taking it on themselves. And then the white coat syndrome in the doctor's office where someone is taking your blood pressure can actually, for some people whose blood pressure is sort of normal, can jump it up just because they're a bit frightened in the moment. But ideally, you want to try to get your blood pressure down to as close to 120 over 70 as you can. And you have to look at blood pressure really in context of the other cardiovascular risk factors, not just as a standalone issue. You know, are they a smoker? Are they overweight? What's their fitness level? What's their LDL cholesterol? What's their HDL cholesterol? What are the triglycerides? What's their glucose level? What's the hemoglobin A1C? All these things factor into cardiovascular risk. But because blood pressure is such a significant one, and it's one of the cardinal risk factors, so high blood pressure, high cholesterol, and cigarette smoking are the cardinal risk factors for cardiovascular disease over and above just age and gender, right? So as you get older, the risk increases. If you're a man, your risk is significantly higher as well. But, blood pressure is one of those things that it can be controlled. And as you lower blood pressure, the risk for cardiovascular heart disease really declines significantly. So lowering a person's blood pressure from 160 over 90 down to 140 over 80 can decrease the risk of heart disease by more than 30%. So it's has a significant impact on cardiovascular health. And patients who are diagnosed with high blood pressure before the age of 30, they carry this increased lifelong risk of having cardiovascular events. Even if the blood pressure is managed, they still have a 40% higher risk of experiencing cardiovascular event. And they really need to be vigilant about lowering their blood pressure using whatever means is possible. People with a history of high blood pressure, they usually have cardiovascular events about 5 years earlier than more normal tenths of people with similar risk factors, all things being equal. If they have other risk factors that are identical, just simply having higher blood pressure can speed up risk of cardiovascular events by 5 years. So in terms of across the population, if we could just get diastolic pressure just down by 2 millimeters of mercury across the population, that alone would result in a 17% reduction in high blood pressure, 14% reduction in risk of stroke and transient ischemic attacks, and a 6% reduction in risk of coronary heart disease, just a 2% drop. So when you start to see what nutrition and lifestyle and supplementation can do to start bringing pressure down by 2 to sometimes 15 points, this has a measurable effect on people's risk factors. So for public health interventions, they're focused on getting human beings to make dietary improvements, become more physically active. These things alone, these are really the basis for the population-wide strategy they're trying to get across. And that's where we can play a very important role in patient education. The Framingham Heart Study showed that men are more than twice as likely to die from sudden cardiac death than women. So men between 45 and 70 years old have just being in that age group alone, have a 10% increased risk of dying from sudden cardiac death, whereas for women, the risk is lower at like 3 to 3.5%, just from being in that age group. But if you have other cardiovascular risk factors, now the risk starts to increase, like high LDL cholesterol as an example, but having high blood pressure really super escalates the risk. So the factors that determine blood pressure, it's multifactorial. There's an interplay of various elements, sort of the neurohormonal system that includes the renin, angiotensin, aldosterone system. We'll come back and look at that. The role of these natriuretic peptides. So the heart, the atrium and the ventricles release these peptides that help to sort of counter the renin and angiotensin system, bringing blood pressure down to normal, washing out excess sodium, dilating blood vessels. These systems start to become dysregulated, you run into problems. Also the endothelium, the endothelial cells are releasing nitric oxide to dilate blood vessels. If you have endothelial dysfunction, because the person smokes cigarettes, they have high cholesterol, they have high homocysteine levels, they're not physically fit, they're a diabetic, then you're not getting normal dilation of blood vessels. You have endothelial dysfunction. And of course, the sympathetic nervous system, when it's ramped up, is releasing adrenaline, but it's also stimulating the kidney cells, the juxtaglomerular cells in the kidneys to release renin, which then is going to kick into gear the whole renin, angiotensin, aldosterone system, which will raise blood pressure, which we will come back to. A nice explanation of the natriuretic peptides, if you're not familiar with them, if you click on that link that you see there, it gives you a really nice review of how that system works. So a malfunction or disruption of any of these factors can actually cause dysregulation of blood pressure. So here's what the factors look like schematically. This is the renin, angiotensin, aldosterone system, where renin gets released, and then it converts angiotensinogen into angiotensin, then it becomes angiotensin 2, which raises blood pressure. The natriuretic peptides from the atrium and the ventricles help to counter that effect. You need normal endothelial function by the endothelial cells in the blood vessels releasing nitric oxide to dilate them, so normal blood perfusion can occur. The sympathetic nervous system is important to how hard the heart is going to beat, peripheral vascular resistance to blood flow, the tone of the muscular coat around blood vessels, and also secreting renin into the system. But also the immune system gets into the act. When there's a lot of pro-inflammatory cytokines being released, it also increases blood pressure. So all these things are interacting at any given time to determine what your blood pressure is. So there's a variety, in terms of lifestyle, there's a variety of non-pharmacological interventions that have been shown to be effective in lowering blood pressure and preventing hypertension. We're going to look at them as a broad stroke overview in this 2018 review article. They say the most effective things are weight loss if a person's overweight, reducing sodium intake, and increasing foods that contain potassium, more physical activity, cutting back on alcohol, and following diets like the DASH diet, which is the dietary approach to stop hypertension. We'll look at that diet shortly. But even small improvements in lifestyle can make a big difference in blood pressure reduction for people whose blood pressure is creeping up. And those even small amounts of blood pressure reduction translate into significant reduction in risk of cardiovascular events. So let's look at the nutritional lifestyle management of hypertension. We'll start with weight loss. So 2/3 of people who are overweight, who have high blood pressure, if they just lose some of the weight, just 10 to 15 pounds usually, their blood pressure goes to normal without any need for medication or any other co-management. Now, if they have other comorbidity problems that require an antihypertensive drug, then they need the drug. If they're a diabetic, then taking an ACE inhibitor drug has been shown to help slow down the decline in kidney function. Even if blood pressure is normal in a diabetic, they still give them ACE inhibitors to help protect the kidneys. I understand that. But in sort of just general overweight with no comorbidity issues, just losing some of the weight, not all of it, brings blood pressure down. Because when a person's overweight, that increased fat mass is putting resistance on blood flow, but it's also raising insulin levels, and insulin increases sodium retention by the kidneys. And when there's more sodium in the bloodstream, it pulls water and you have more blood volume. So the heart has to work harder to pump the blood, and there's more peripheral resistance as well because there's more volume in the system. It's estimated that up to 50% of adults in the United States whose blood pressure is being pharmacologically managed, the need for drug therapy could be alleviated with only modest reductions in body weight. And I think this message is being lost in the mix. I don't know if doctors are talking to patients enough about how important it is to start getting that body fat down. With respect to exercise, we know that regular aerobic and endurance exercise reduces blood pressure. It's a standard recommendation by the major hypertension guideline groups around the world. And so the idea is to work up to 30 to 45 minutes at least 4 times a week. Even in people whose blood pressure is normal, it helps to bring their blood pressure down a little bit. But in hypertensive patients, the reduction in blood pressure is greater than in people who are normal tensive. So that people who have high blood pressure are getting an even greater benefit in terms of blood pressure reduction when they do aerobic exercise. It's a rule. Exercise significantly decreases the systolic and diastolic daytime ambulatory blood pressure by an average of 6 points systolic and 3 points respectively diastolic in patients who are drug-resistant hypertensive patients. So some patients, you give them medications, it doesn't bring their blood pressure down enough. When they add exercise to the mix, they get a further drop, which is significant. So it's a very important sort of adjunctive way to manage blood pressure. And it should be included in the therapeutic approach to resistant hypertension. That should just be an automatic thing that patients are aware of now. The decrease in post-exercise blood pressure, how does that occur? Because when you're exercising, the adrenaline's being released, the sympathetic nervous system is firing, your blood pressure is going up while you're exercising. But when exercise is over, the baseline levels of adrenaline go down to what they were before the exercise started. And then sort of the heart muscle is not contracting as hard, there's less peripheral resistance, and your pressure is going down. Now, resistance training may also help, but if a person already has high blood pressure that's quite high, like 180 over 110, you don't put this person on a weight training exercise program because that'll take the pressure too high, they could have a stroke. So you don't introduce weight training to someone who has blood pressure that's very high and is not being managed well. On the other hand, day-to-day weight training for normal tense of people with mild hypertension, causes these great vasoactive effects that actually could also contribute to lowering blood pressure in conjunction with aerobic training. I wouldn't just do that without aerobic training, but if you add it on, you get an additional benefit. Part 3, sodium intake. So we know that in societies around the world where sodium intake tends to be low, hypertension incidence and its complications are much lower. As salt intake starts to creep up, as it does in developed countries, you're getting a greater amount of hypertension that's more difficult to manage. Now, not everybody is a sodium sensitive person when it comes to high blood pressure. Only about 26% of people with normal blood pressure are sodium sensitive. That means if you gave them more sodium, their blood pressure would rise a little bit. But 51% of people that have high blood pressure are sodium sensitive, whereas 33% are sodium resistant. That means that for that 33%, if you lower their sodium intake, their blood pressure remains high anyway, because sodium's not the problem for them. So reducing sodium intake does not reduce blood pressure in all hypertensive patients, but it does lower it in the majority of cases. So it is worth having that as part of the strategy, as you'll see. The underlying mechanism around salt sensitivity is not really well understood, but we know there's a sort of a genetic environmental sort of interplay here. But among environmental factors, dietary salt intake is the most common and important risk factor for hypertension. Because 50% or more of individuals are affected by it who are hypertensive patients, getting that sodium down can play a huge role in helping those patients in particular get their blood pressure into the ideal range. So you have to look at our human ancestry to understand this. Our hunter-gatherer ancestors weren't having a lot of sodium. So maybe 1,000 milligrams a day, but then when they moved to more agricultural-based society, which is fairly recent in terms of human history, they started using more salt to preserve their foods, and our sodium intake increased. And as sodium intake increased during the agricultural period, the Industrial Revolution, and the Scientific Revolution, the Digital Revolution, that we have a lot of sodium in our foods today. And our bodies are not really made for this kind of sodium assault. And so we can't really, in a lot of cases, excrete it highly effectively. So as it stays in our system and it binds to water, the blood volume goes up and there's more peripheral resistance. So larger increases in salt intake over the years has now been a main factor in increasing worldwide hypertensive statistics. 30% of the adult population worldwide has high blood pressure. So it's one of these risk factors that sometimes slides under the radar, sort of a silent killer. You don't feel it from day to day, but in the background, it's doing a lot of damage. And some of the more salt-sensitive individuals are Blacks, diabetics, and as people get older, they usually become more sodium sensitive as well. So reducing sodium intake down to 2,000 milligrams a day from roughly 3,000 milligrams a day, where it is on average, globally can make a huge difference. So that really means restricting discretionary salt use, avoiding heavily salted and processed food like prepared soups and pickles and a lot of salted snack foods, things with MSG. There's a great link that I'm giving you here that shows you the sodium content of most common foods, if you really want to see how many milligrams they contain. This is worth looking at once in a while just to refresh your memory as to where that sodium is coming from. But they created the DASH diet developed by the National Institutes of Health. DASH stands for Dietary Approach to Stop Hypertension. So it's a diet that reduces sodium intake and increases from food potassium, calcium, and magnesium to reduce high blood pressure, but it also has nutrients like calcium and magnesium to protect against osteoporosis, other phytonutrients to protect against cancer and heart disease and diabetes. So the DASH eating plan requires no special foods, but it provides daily and weekly nutrition goals, eating more vegetables, fruits, and whole grains, staying away from high saturated fats foods, using a lot of leaner proteins, things that I talk about all the time, including some nuts. and staying away from the fatty meats and the fatty dairy products and the tropical oils, and keeping the refined sugars lower. So it's really just a very prudent type of diet. If you want to look at the details of the actual DASH diet, the Mayo Clinic shows a beautiful breakdown of the guidelines for patients that have been shown to be very helpful, as you're going to see. So in 2018, there was a study that was published they had these 3 groups. It took almost 130 overweight or obese men and women between age 40 and 80 who had already had high blood pressure. Some of them met the inclusion criteria for blood pressure medication, but none of them were taking any medication when the study began. More than half of these subjects actually met the criteria for high blood pressure meds. So each of the patient was assigned to one of 3 groups. So the first group, and all of these groups, the study period was 16 weeks. So for the first group, they gave them a diet plan with exercise, supervised exercise, weight loss counseling, and the DASH diet. And they did exercise 3 times a week that was supervised to make sure we knew that they were doing it. It wasn't just self-reporting. The first group also adopted the DASH diet that I just showed you. The second group, they just did the diet only, focusing on the DASH diet with the help of the nutrition, but there was no exercise or weight loss counseling. Remember, they were all overweight. The third group didn't change their exercise or eating habits at all. They're like a placebo group, just the control group, if you will. So after 16 weeks, it showed this at the first group who followed the DASH diet. They participated in weight management counseling with a dietitian, and they had supervised exercise. They lost 19 pounds. This is just in like 4 months now. And they reduced their blood pressure by an average of 16 millimeters of mercury systolic and 10 points diastolic. That's huge. The ones just following the DASH diet with no exercise or weight loss count, they had a fairly decent improvement as well, 11 points systolic and 8 points diastolic. And the groups who were just left to their own devices, I guess because they knew they were in a blood pressure lowering study, probably improved their behaviors a little bit, and they saw a very mild or modest reduction in systolic and diastolic pressure. But you see, when you start to add, when you do things in conjunction, you add exercise and weight loss and a healthier diet, that you start to get this combined effect that is outstanding. So by the end, only 15% of those who changed their diet and their exercise habits were still candidates for high blood pressure medication, versus 23% that only changed their diet. So in other words, a lot of these people who would have been put on medications at the beginning of the study, when they changed their diet and exercise habits and lost some weight, as 4 months later, they weren't even candidates for blood pressure lowering medication. That's the power of lifestyle intervention. No change in the control group. 2017 study in the Journal of the American College of Cardiology showed that the dietary approach to lowering high blood pressure can outperform the blood pressure lowering effects of some high blood pressure medications. That's amazing. So this study involved 400 patients with stage 1 high blood pressure. 50% of the participants followed the DASH diet and 50% ate the typical North American diet. Participants in both groups were also fed low sodium, medium sodium, or high sodium bait over the 4-week period. So you see low sodium was 1,500 milligrams or less. An intake of 2,300 milligrams of sodium is sort of what they're saying is sort of the cutoff point that should be used across the population. So the results of this study said, compared to individuals who ate the typical North American diet, along with the high sodium content that the diet usually has, the individuals who followed the DASH diet along with the low sodium regime, staying down to 1,500 milligrams of sodium, showed a significant reduction in systolic blood pressure. In fact, the higher their initial blood pressure, the greater was the reduction of blood pressure. In one subject with an initial blood pressure of over 150 systolic, the systolic pressure dropped by 21 points in 4 weeks. Diet alone. Most of the participants saw reductions between 5 and 10 points, which is extremely impressive when you consider the fact that to get a blood pressure drug approved, you must lower blood pressure by at least 5 points. That's what a lot of low ceiling diuretic drugs do. They lower your blood pressure by 5 points. So here you see dietary interventions can lower it 5 to 10 points. Even the most effective high blood pressure drugs are only lowering things by 5 to 15 points. That's why they start, sometimes you see this on an intake questionnaire. What medications are you taking? And they list like 4 or 5 antihypertensive drugs. They're trying to get a compounded effect of all the drugs to get the blood pressure down, because one drug by itself, as powerful as it can be, can often only lower pressure by 10 to 15 points. So they start stacking them. So diet and lifestyle can go a long way. It's one researcher stated in the conclusion of this study, what we're observing from the combined dietary intervention, DASH plus low sodium, is a reduction in systolic blood pressure as high as, if not greater than, that achieved with prescription drugs. Our results add to the evidence that dietary interventions are as effective as or more effective than antihypertensive drugs in those at highest risk for high blood pressure, and should be a routine first-line treatment option for these individuals. So even in standard textbooks of pharmacology, they tell doctors the very first thing that you do is you use the first line of antihypertensive strategies is non-pharmacologic. That's the first thing you do. And then when you see how that works, if you need to add blood pressure drugs after, then you add them. But that's not what happens. And so patients don't feel that lifestyle is a big deal because it's not emphasized enough often in the consultation. For patients whose systolic blood pressure is at or above 150, these should be the first form of treatment attempted, or at least should be complementing the drug therapy. Now, things get more complex if the person's already a diabetic or they have other health complications. They have heart valve disease or mitral valve replacement. They've already had a stroke. That factors into the need for drugs, even if the blood pressure is normal. I don't argue with that. But in the otherwise garden variety, high blood pressure patient, no other comorbidity issues, very often non-pharmacological agents those interventions can be the primary and only intervention required to get blood pressure down. And that is not appreciated enough. So we go to strategy number 4, which is alcohol. There's a strong correlation between alcohol consumption and elevated blood pressure. A single drink can have an acute effect on raising blood pressure, but it resolves usually within a couple of hours. What we see is that the effect of alcohol on blood pressure, this is sort of the take-home gem, is that your blood pressure is affected by the alcohol you've had over the last few days. If the person stops drinking alcohol, a week later, it's not having a sustained or continued effect. So there's no latent effect to alcohol consumption. So if you're trying to get blood pressure down in someone who drinks routinely, by getting them to cut alcohol out of their diet or to cut back significantly, that will lower their blood pressure, in the very near term, because alcohol is only affecting blood pressure for a short period of time after its consumption. So it's the few days immediately preceding blood pressure measurement with alcohol before those few days exerting little effect on blood pressure. So it's really what's happening in the recent past in terms of alcohol consumption. Even in heavy drinkers and alcoholics, we see the same thing, that if they stop drinking, their blood pressure starts to go down a number of days later, and there's no long-term alcohol-related effects after they stop drinking. So the recent epidemiological clinical studies have demonstrated that chronic alcohol consumption, more than 3 drinks per day, is associated with an increased incidence of high blood pressure and increased risk of cardiovascular disease. The magnitude of the increase in blood pressure in heavy drinkers is about 5 to 10 points systolic, and increases nearly always greater, which is usually greater than the diastolic increase. So usually there's more systolic increase. Alcohol tends to make the heart muscle contract with more force. That tends to be the profound influence. In the Framingham Heart Study, an increase of 7 millimeters of mercury in mean arterial pressure when heavy alcohol uses were compared with all others. So the more people drink, usually the higher, the greater the effect is of alcohol consumption. How does alcohol increase blood pressure? By increasing sympathetic discharge, altering the function of the baroreceptor, stimulating the adrenals to release more adrenaline, affecting the renin-angiotensin system, releasing cortisol, and increasing the release of intracellular calcium, which then causes smooth muscles to contract, creating more peripheral resistance. So One of the things that people that have high blood pressure that I try to get them to do is to get alcohol out of their diet altogether, to see what effect it's having. Oftentimes that'll bring your pressure down by 5 points just in and of itself within the first week or two. And then you know that alcohol is a bit of a culprit for them. Calcium supplementation, a large number of well-designed studies have shown that calcium supplementation, whether it's calcium carbonate or citrate, it doesn't matter. It helps to wash sodium out of the kidney. So the more calcium you consume, the more calcium is resorbed by the kidney tubules, which is in exchange for sodium being flushed out of the body in the urine. So it actually helps to increase the excretion of excess sodium. So calcium by itself lowers blood pressure by just a couple of points, as you're going to see. But if the person at the same time is lowering their sodium intake as well, the combined effect is very significant. So the 2015 Cochrane database reviewed all these calcium supplementation studies involving over 3,000 patients in 16 trials. It showed that it reduced systolic pressure and diastolic pressure by, a couple of points respectively. But when you got calcium intake between 1,000 and 1,500 milligrams, once you start getting up around 1,500 milligrams, the reduction is even greater. So we noted a reduction in blood pressure in men and women and at ages 11 to 82 years old, but the reduction was greater among younger people. In other words, as people get older, giving them more calcium when they're 75 or 80 years old doesn't necessarily give you the same blood pressure lowering effect as it does in people who are younger. So you see these modest reductions in people who are under the age of 35. But when you combine that with decreased sodium, you start to get a more significant effect. Same with magnesium. There's some studies showing that magnesium supplementation lowers blood pressure, but not all the studies agree with that. The evidence is greater for calcium. But when you add magnesium to calcium, that's when you start to get a nice, more of a synergistic effect. There's really no risk in adding the magnesium unless the person has chronic kidney disease. So anybody that has sort of more advanced chronic kidney disease, they have trouble excreting excess magnesium. And so they can develop hypermagnesemia, which can actually put the heart into atrial fibrillation. They can die. So you can't just randomly giving people, as much magnesium as, that's sort of an arbitrary number. If the person, you have to know if they have, chronic kidney disease, because if they do, then magnesium supplementation has to be much lower or not at all. So here's the 2016 review of magnesium and blood pressure. 34 clinical trials involving over 2,000 patients. It's meta-analysis showing that a median dose of about 368 milligrams of magnesium for a duration of 3 months significantly reduced blood pressure by 2 points systolic and by almost 2 points diastolic. But that's actually very significant. And they also saw a rise in serum magnesium versus the placebo groups. So, getting that additional couple of points reduction from magnesium is not something to take lightly. Just a couple of points makes a difference. We found that magnesium supplementation with a dose of 300 milligrams for just 1 month is sufficient to elevate serum magnesium and reduce blood pressure. And as serum magnesium goes up, blood pressure tends to go down. That seems to be the correlation. The mechanism of action through which magnesium works is sort of multi-faceted, and I'll send you these slides at the end. You can read all of the details below, but I have to keep moving in order to sort of meet our timeline for today. There's also the omega-3 fat supplementation story. So over 60 double-blind studies have demonstrated that either fish oil or flaxseed oil supplementation can be effective in lowering blood pressure. Just 1 tablespoon of flaxseed can lower systolic and diastolic pressure by up to 9 millimeters of mercury. It's a significant reduction. So here's a 2014 review looking at fish oil, EPA, DHA, and blood pressure reduction. 70 randomized control trials showed the following. Overall, the available evidence from randomized control studies indicate that having more EPA, DHA intake reduces systolic blood pressure, whereas to get a diastolic reduction, you need to be getting at least 2 grams a day of EPA and DHA. So you need to be getting higher doses to get the diastolic pressure down. And we'll come back to that. Now with flaxseed oil, which is really not appreciated as much as it should be, people talk about fish oil all the time. But the human body can convert the alpha-linolenic acid, omega-3 fat in flaxseed oil into the omega-3 fats, DHA and DHA, EPA and DHA. And while it's doing that, it's slowing the conversion of linoleic acid into arachidonic acid, which is a good thing because arachidonic acid causes prostaglandin series 2 to be formed, which increases vasoconstriction, produces inflammation. So flaxseed oil, in addition to fish oil, not instead of, but in addition to, has a nice synergistic effect. So many people don't appreciate the benefits of fish oil, but the studies show that flaxseed oil on its own has a lot of health benefits. It's 57% pure alpha-linolenic acid. So in 2005, the National Heart and Lung and Adult study, one of the first studies to show that higher intakes of alpha-linolenic acid from flaxseed oil was associated with lower blood pressure. They also showed that higher adipose tissue alpha-linolenic acid is also related to lower blood pressure in large groups of people from 25 to 93 years old. Then there's this published study in 2007 in the European Journal of Clinical Nutrition. They used supplementation of flaxseed oil that reduced high blood pressure in high blood pressure patients who also had other risk factors for heart disease that had high LDL cholesterol and low HDL cholesterol. So in this 12-week study of 87 male volunteers aged 35 to 70 years old, so a broad range of age, they had high blood pressure and high LDL cholesterol and low HDL, major risk factors for cardiovascular disease. One group was given safflower seed oil, which is high in the omega-6 fat linoleic acid, which you don't want to be taking. And the other group got flaxseed oil, which is 57% alpha-linolenic acid and omega-3 fat. After 12 weeks, the flaxseed oil group realized a drop in systolic and diastolic blood pressure of 5 millimeters of mercury. No change in the safflower group. And here's what's really key, that for every 2-point decrease in blood pressure, the risk of heart disease decreases by 7% and the risk of stroke by 10%. So a 5-point drop in systolic and diastolic pressure translates into a significant reduction in risk. This should not be taken lightly. Every 1 or 2 points makes a big difference in terms of risk. In vitro studies also show that flaxseed oil reduces risk of atrial fibrillation, which affects 9% of people over the age of 65. So that's another reason to consider flaxseed oil. And consistent with these findings, studies link increased intake of alpha-linolenic acid with a reduction in sudden death and non-fatal heart attack. The more you enrich your cell membranes of your cells with alpha-linolenic acid from flaxseed oil, the lower the risk of these major events seems to occur. And experimental evidence also shows it can help to reduce risk of colon cancer. I just thought I'd throw that in because flaxseed oil studies in prevention of colon cancer is becoming, there's more published data on this every year. And, you know, colon cancer is like the second leading cause of cancer death. So getting flaxseed oil each day into your body, I think, is something you should have on your radar, whether you have high blood pressure or not. And the whole story around omega-3 fats, of course, is that over the last 100 to 150 years, our consumption of vegetable oils that are high in the omega-6 oils, particularly linoleic acid, corn oil, sunflower seed oil, safflower, cottonseed, soybean oil, these things have drastically created a high omega-6, low omega-3 imbalance. That's 20 to 30 to 1, which is not really what our bodies are designed for. So getting more fish into your diet, supplementing with, you know, fish oil, flaxseed oil. I also like borage seed oil, as you're going to see, to try to bring this balance back and reduce inflammation in the body and improve the omega-3 index makes good sense. So a direct quote from the 2015 review paper on flaxseed states, "A large number of clinical studies have recognized the tremendous potential of omega-3 fats against inflammatory mediators like prostaglandin 2, leukotriene B4, tumor necrosis factor alpha, inflammatory interleukins, and inflammatory cytokines. These clinical studies revealed that omega-3 fats are helpful in prevention of coronary artery diseases, atherosclerosis, rheumatoid arthritis, and asthma. So paying attention to that balance every day of your life is critically important for a multitude of reasons. Here are the references on flaxseed oil alone. Now we come back to the omega-3 fat story, broadening this out to include fish oil. So in the journal Hypertension in 2018, they said ingesting more omega-3 fats at a younger age is associated with prevention of early onset high blood pressure. How about that? In this study, researchers examined over 2,000 young people ages 21 to 40, tracking their blood pressure during office visits and using a 24-hour blood pressure monitoring device to track it throughout the day. They also drew blood to evaluate the omega-3 fat content of the red blood cells. So they give these people what's called the omega-3 index. So in the cell membranes of red blood cells, if 8% of all the fats that are esterifying the lipoproteins in there are from omega-3 fats, then your omega-3 fat index is 8%. If only 4% of the fats esterifying the phospholipid structures are from omega-3 fats, your index is 4%. So remember that the fats that you eat determine which fats are going to esterify the lipoproteins in your cell membrane. So what they're saying is that previous studies have shown that having an omega-3 index of 8% or higher is strongly linked to lower blood pressure in older subjects. So it's not just about young people, as well as decreased risk of many cardiovascular problems, including congestive heart failure, heart attack, and stroke. Omega-3 fat index, I think, is very important. The 2018 study showed that even younger people, ages 21 to 40, that had higher omega-3 index, associated with a significantly lower risk of having borderline high blood pressure or high blood pressure, even at this early stage in life. So starting even in youth, paying attention to the omega-3 intake and starting to move away from the unhealthy omega-6 fats is important. Studies show that on a monthly basis, every 4,000 milligrams of EPA and DHA you ingest, either from fish or from fish oil supplements, increases your omega-3 index by 0.24%. So over a number of months, you can get that index up. Here's the fish with the highest omega-3 fat content. Remember, some of these have a lot of mercury, so be careful. Same with the intermediate ones. You wouldn't want to be eating swordfish as an example. This is my personal comment on this. I recommend to most people that they take an essential fatty acid supplement that is 400 milligrams of a high yield fish oil. That means at least 30% EPA, 20% DHA, along with flaxseed oil, 400 milligrams, and borax seed oil at 400 milligrams. Taking 3 capsules a day of that is going to get you 2,400 milligrams of your omega-3 fats, which is really the target, along with gamma-linolenic acid from borax seed oil, which helps the body make anti-inflammatory prostaglandins, which is also important to keep the inflammatory index down. So in recent years, the incidence of high blood pressure among young people ages 20 to 39 has increased from 4% in that subgroup to 19%. Increasing their omega-3 fat index is one of the key ways to help to stem that tide. So just to review, of course, here's linoleic acid in corn oil, sunflower seed oil, safflower seed oil. And the body converts that to arachidonic acid, which produces these prostaglandin series 2 hormones that cause inflammation and can constrict the blood vessel wall and have a negative effect on blood pressure and all kinds of other diseases. Whereas alpha-linolenic acid from flaxseed oil can be elongated to EPA and DHA, which are the same omega-3 fats found in fish oil. And from there, you form prostaglandin series 3 that makes the blood less sticky. It dilates blood vessels, it reduces inflammation. And while the flaxseed oil is being converted along this line, it's decreasing the conversion of linoleic acid into arachidonic acid. Gamma-linolenic acid can be converted to prostaglandin series 1, which is anti-inflammatory in the presence of antioxidants, B vitamins, zinc, and other minerals. If you take a high-potency multivitamin and you're getting gamma-linolenic acid, then this conversion becomes much stronger than this conversion to arachidonic acid. So you want to get this sort of multifaceted approach, which I'll show you at the end of the slide series here. Now, garlic supplements can also lower blood pressure more in some people and less in others. It's really mixed across the board. It would have to be 4,000 micrograms of the active ingredient allicin, which is sort of a sulfur-containing allium allicin molecule. So reductions can be quite significant, but it really varies across hypertensive subjects. And there's some evidence to show that garlic supplements can also lower cholesterol, make platelets less sticky, and enhance immune system function, has antioxidant properties. These organosulfur compounds are tremendously important to human health. The problem is that when you take them in a concentrated dose like a supplement, although it can lower blood pressure, then the evidence is limited as to how much and can it really do it and to what extent. The fact is that there is a major risk with using garlic supplements, and that is that it can increase risk of bleeding. There are human case reports of internal bleeding with garlic supplements. I like garlic as a condiment in food. I never recommend to people that they take garlic supplements because of the risk of bleeding. That's just my own personal viewpoint on it. You may have a different viewpoint, but you can read the literature for yourself and make that determination. Strategy number 9 is coenzyme Q10, which I strongly recommend. The randomized studies on CoQ10 are just so impressive. It can effectively and consistently lower blood pressure in hypertensive patients. It's also increasing the bioenergetics of the heart, so you help to guard against congestive heart failure as you get older. 39% of patients with high blood pressure have a deficiency in coenzyme Q10, and when you give them CoQ10, you correct that deficiency. Experts show that CoQ10 lowers blood pressure in a number of ways, but a really key way is that it increases the release of nitric oxide from the endothelial cells in the arterioles, which then dilate the blood vessels, decreasing peripheral resistance, and can bring blood pressure down quite significantly, as you're going to see. So the addition, giving people 60 milligrams of CoQ10 twice a day can lower blood pressure, in these trials to a significant level. As I said, I'll show you the numbers in a moment. But that level of CoQ10 can also have other great effects on health parameters like lowering insulin levels, lowering glucose levels, lowering triglyceride levels, and lowering free radical biomarkers in the blood like malondialdehyde. So CoQ10 has this multifaceted, multidimensional molecule. Remember, the body's synthesis of the CoQ10 declines as we get older, so it has all these great effects. It can be taken safely in conjunction with antihypertensive drugs to produce a better blood pressure lowering outcome. So here you see some of the numbers. 60 milligrams twice a day, or in some cases 100 milligrams once a day. In mild cases of hypertension, 30 to 75 milligrams once a day has also been used to normalize blood pressure. Here are the studies. 2007 review in the journal Hypertension. So these are not Mickey Mouse little publications. A meta-analysis was performed of 12 clinical trials where they used coenzyme Q10. 3 were randomized, 1 was a crossover study, and there were 8 open label studies. In the randomized control study, the systolic blood pressure in the treatment group decreased by 16 millimeters of mercury, 16 millimeters of mercury in the control group, in the group that got the coenzyme Q10 supplementation, and their diastolic pressure dropped by 8 points. So if you go back to what we were saying about blood pressure lowering medications, if you can get a reduction of 5 points, that's really good. 10 points is outstanding. So here's CoQ10 reducing systolic and diastolic pressure by 16 and 8 points respectively. That's incredible. In the crossover study, they saw a reduction, 11 millimeters systolic and 8 points diastolic versus the placebo. In the open label trials, you also see significant reductions. So there's consistent evidence to show that coenzyme Q10 supplementation is very valuable to lower blood pressure. It has the potential to lower systolic blood pressure by up to 17 points and diastolic pressure by up to 10 points without any side effects. And it can be used in conjunction with other blood pressure lowering medications. There's no contraindications there. Remember that one of the ways that it's doing this is by increasing the release of nitric oxide. So nitric oxide, when it's released by the endothelial cells in the arterial bed, dilates blood vessels. It reduces free radical damage to the LDL cholesterol, and also makes platelets a little less sticky. It stops the white blood cells, the monocytes, from sticking to the endothelial bed and becoming macrophages, which then ingest LDL cholesterol, forming atherosclerotic plaque. This is a huge thing to be able to increase nitric oxide from endothelial cells. So now we see a patient who goes on a statin to have, let's say they're developing congestive heart failure, or they have high cholesterol rather. They put them on a statin drug here, and because statin drugs decrease the synthesis of coenzyme Q10 as a side effect, you notice that as CoQ10 drops, the heart muscle contraction ability also drops. The ejection fraction goes down. They go off the statin drug and notice that the CoQ10 comes back up and their heart muscle starts to increase with more force. So when people go on statin drugs, they need to be put onto CoQ10 so they don't end up with a CoQ10 deficiency and end up having congestive heart failure while they're bringing their cholesterol level down. You'll notice that in the aging process, look at the amount of CoQ10 in the heart muscle. By the time you're 40 years old, it's declined significantly from a 20-year-old. By the time you're 40 years old, you need to be taking CoQ10 supplements anyway, just to guard against congestive heart failure. And if you're on a statin drug before age 40, the person needs to be on CoQ10 the minute they start taking a statin drug. So the 2018 review in the Journal of Hypertension says that CoQ10 significantly improved not just bringing blood pressure down, but it improved vascular function in healthy older adults. It reversed vascular changes by the equivalent of 15 to 20 years in these older subjects after just 6 weeks of supplementation. Just 20 milligrams a day. It's not even that much. Whereas the group that got the placebo, no change in their vascular performance. Researchers found that taking CoQ10 dilated their arteries and it improved it by 42%, making their blood vessels at least by that measure look like those of someone 15 to 20 years old. You can reverse age-related changes to your vascular system. An improvement of that magnitude, if sustained, is associated with about a 13% reduction in heart disease. The study also showed that the improvement in dilation was due to the reduction in oxidative stress. So not only is it important to release more nitric oxide, but that decrease in oxidative stress is also very important. That's why other antioxidants can also be important to maintaining vascular integrity. So Dr. Rossman explains blood vessels grow stiff with age, largely a result of oxidative stress and the excess production of metabolic byproducts called free radicals, which can damage the inner lining of blood vessels, impairing its function. CoQ10 is an antioxidant that quenches these free radicals in the area of the mitochondria to also improve the energy factory of the cell. And CoQ10 declines with age. You've got to put it back in. It also releases nitric oxide from the artery wall. And here's all the references on CoQ10. You should read them. It's so impressive. I like CoQ10 with Hawthorn because studies show that the bioflavonoids called procyanidins that are found in Hawthorn also improve the bioenergetics of the heart, working with CoQ10 to make sure that the mitochondrial function is ideal for ATP production to prevent congestive heart failure and to help manage early stage congestive heart failure. But it can also lower blood pressure as well, just like CoQ10, by a number of mechanisms, but it also helps to dilate blood vessels by releasing nitric oxide, as you're going to see. If it's used as the only intervention for high blood pressure, you need a dose pretty high of 100 to 250 milligrams a day, but normally you would have it in conjunction with CoQ10. But Hawthorn has to be a standardized grade of 5% flavonoids. So flavonoids in Hawthorn are the active constituents. Usually it takes 2 to 4 weeks before you see a blood pressure reduction effect in the person. So they can't just take it for 3 days. They didn't do anything. They need to take it for, a couple of months before you really know, at least a month. The thing to remember with Hawthorn is that you don't take it with digitalis or digoxin. Any of those types of drugs, Hawthorn is contraindicated. Here's a systematic review of Hawthorn published in 2020 in the Journal of Advanced Integrative Medicine. There were really only 4 really good clinical studies that met the inclusion criteria. So it's only 254 patients in total, not that many really. But the systemic review found that Hawthorn can significantly lower blood pressure in people with mild hypertension if applied for at least 12 weeks. So they're saying, you know, a longer period of test time is actually required if it's used as the only intervention. But when you combine it with CoQ10, the effects really do happen sooner. No serious adverse effects were reported. In 2010, there was this other review paper on Hawthorn showing it has other effects that help to preserve endothelial function, vasodilation of the blood vessels, so you get better circulation. And then they talk about in chronic heart failure, the value of using Hawthorn, especially in the early stages, as you're going to see in the upcoming slides. So this little review here of Hawthorn and congestive heart failure is very important because it shows that in people with early stage mild to moderate heart failure, Hawthorn, like CoQ10, is highly efficacious and should be used. In more seriously ill patients with more advanced heart failure, they need higher doses of Hawthorn, and it doesn't always work. So, you know, again, like anything else, the more seriously ill the person is, the less likely supplements and things that are natural are going to likely be, you know, extremely helpful. Catching these things early and applying the best known complementary medicine as early as possible is always the best step here. Has an excellent safety profile, not a lot of herb-drug interactions, but digitalis is the big one that should stand out in your mind, and very helpful in early stages of congestive heart failure. It really should be used more. Then this takes us to beetroot juice. So beets contain a lot of natural nitrates, which the endothelial cells can convert into nitric oxide, dilating blood vessels, reversing endothelial dysfunction. So researchers have concluded that 8 ounces of beetroot juice a day is enough to significantly lower blood pressure in people with high blood pressure. I'm going to show you a great study here from Queen Mary University in London. 64 adults, 18 to 85 years old. Half of them were already taking prescribed medications for blood pressure, but didn't reach their target goal. So they're a little bit sort of drug resistant. And the rest had been diagnosed with blood pressure, not yet taking medication. So randomized double-blind study, half of the participants ingested 8 ounces of beetroot juice for 4 weeks, and the other half ingested beetroot juice, but the nitrates were removed. So it's a great study because, you know, the drinks were identical. During the study, patients drinking the beetroot juice had a drop in blood pressure of 8 points systolic and 4 points diastolic. That's like taking drugs. In the 2 weeks after the study, when no beetroot juice was consumed, the people who had the beetroot juice, their blood pressure went right back up. So that's a great test. They're on the beetroot juice, their blood pressure goes down. They go off it, the blood pressure goes back up, right? So whereas the placebo group saw none of these changes. So it really gave tremendous evidence that the beetroot juice, the nitrates in the beetroot juice were producing this great vasodilatory effect. The drop in blood pressure facilitated by beetroot juice is comparable to the drop in blood pressure from many high blood pressure drugs, whereby a single blood pressure drug reduces blood pressure by 9 points systolic and 5 points diastolic, very similar to what beetroot juice was doing. They conclude the findings suggest a role for dietary nitrate as an affordable, readily available adjunctive treatment in the management of patients with hypertension. Beetroot juice is actually fairly expensive, so you can get a juicer and just sort of put beets in there and make your own and add some other flavors to it if you like. 8 ounces a day. Then, of course, there's meditation, progressive relaxation, biofeedback training. I don't have to tell you how important your brain is to shutting down the sympathetic nervous system. Studies show that it can produce a decline in blood pressure. That shouldn't surprise anybody. So here's some great references for that if you want to see how people have done it using sort of mind-body work to bring your blood pressure down, something I highly endorse. And remember that the way that that's working to a large degree is not only shutting down the sympathetic response, but also remember the sympathetic nervous system. What it does when it's turned on is it causes the juxtaglomerular cells in the kidneys to release renin. And then renin converts angiotensinogen released by the liver into angiotensin 1. Angiotensin 1 goes through the circulatory system of the lungs and gets converted by the ACE enzyme into angiotensin 2. And then once you have angiotensin 2, you get all of these increased effects on sodium resorption, vasoconstriction, raising blood pressure. So a person's mind, when they're in sympathetic overdrive, is in our time urgency world with lots of stress and lots of chronic stress. A lot of people don't even realize that they're sympathetic dominant all day long. And that sympathetic drive, and the doctors go, it's idiopathic hypertension. A lot of times it's just that their sympathetic nervous system is sort of on overdrive, and they don't even realize it because that's what feels normal to them. And so they are constantly, their sympathetic nervous system is firing, and the renin angiotensin system is up and running, and that's causing this background blood pressure to be elevated all the time. So this is where relaxation, meditation, biofeedback can be an important role. And this is where exercise, aerobic exercise, also plays a key role in bringing that baseline adrenaline to a lower level and a lower sympathetic nervous system drive down to lower than baseline when the exercise is over. These things really can make a difference, and they're often not talked about sufficiently. The last thing I want to touch on here is marijuana and medical marijuana, because it's becoming, a much more common thing in our society. So, in marijuana, you have the psychoactive THC, which is the delta-9 tetrahydrocannabinol, and you have CBD, which is non-psychoactive, right? Just cannabidiol. So it's the THC, the psychoactive part most people like, that dilates blood vessels by increasing nitric oxide release, but that can create then a precipitous drop in blood pressure, which causes the heart to start beating faster and harder. So you often get this reflex effect where the heart is pounding harder and faster. In patients with risk factors for heart disease and or patients with previous heart interventions, bypass surgery, stents, angioplasty, valve replacements, THC may increase the risk of cardiovascular events, similar to patients taking Viagra. Does the same thing. This huge release of vasodilatory effect, and you get the sudden drop in blood pressure, and then the heart responds, and sometimes they go into cardiac arrest within hours later. So there's some studies to show this. So in 2019, Harvard Health Publishing, looking at THC and risk of cardiovascular disease, people with established heart disease who are under stress develop chest pain more quickly if they've been smoking marijuana than they would have otherwise. We don't need, and I think the same thing applies to edibles as well, by the way. Just that getting a THC in your body is a bit risky. THC raises resting heart rate, dilating blood vessels, and making the heart pump harder. Research suggests that the risk of heart attack is several times higher in the hour after smoking marijuana than it would be normally. When this does not pose a significant threat to people who have minimal cardiovascular risk, it should be a red flag for anyone with a history of heart disease. So these cardiac risk patients, that's where the red flag is. The evidence is weaker for atrial fibrillation and for stroke, but there's still some evidence for it. Marijuana smoking may increase the long-term death rate among heart attack survivors. So anyone with a previous history of a heart attack, if they're using THC on any level, even if it's an edible, they might be putting themselves at risk. More evidence here in 2019. THC has three major effects on the cardiovascular and peripheral vascular system, causing inflammation of the arteries, cannabis arteritis as it's called, also causes vasospasm and increased platelet aggregation. So we have this effect even maybe on atherosclerosis progression. So remember this, so there's CB1 receptors and CB2 receptors. The CB1 receptors in the body respond to THC, and the CB2 receptors bind, or CBD actually binds more to the CB2 receptors. So the CB1 receptors are sprinkled throughout the vascular system, the central nervous system, peripheral vascular system. So THC causes an acute dose-dependent increase in blood pressure and heart rate. That's the thing I want you to get to. The other thing is that because there's some sort of tolerance over time, people start using higher and higher doses to get the psychoactive effect that they're looking for, that sort of marijuana high. There's evidence to suggest that increased frequency of marijuana use increases risk of cardiac arrhythmias and myocardial infarction. Chronic THC use has been associated with increased angina frequency and also raising aldosterone and vasoconstriction and hypertension. So I just want you to be aware of, because medical marijuana and the use of legalized marijuana is going to come up in discussions with patients. So your patients who have cardiac risk factors, I would try to discourage them from using it on any level of regularity, even if it's an edible. So here's the summary of today's talk. Reducing high blood pressure naturally, the World Health Organization has promoted lifestyle modification as an effective method of reducing high blood pressure and overall cardiovascular risk. A summary of effective natural antihypertensive interventions include the person's overweight just losing some of the weight. Get their sodium intake down. Get it down to 2,000 milligrams or less if possible per day. Try to get alcohol out of their diet, at least get them to cut down to something that is judicious. Get them doing aerobic exercise, building up slowly over time, getting more calcium and magnesium into their body, trying to hit those targets of 1,000 to 1,500 milligrams of calcium. Helps with osteoporosis anyway, and maybe 300 to 600 milligrams of magnesium from food and supplements. And then flaxseed and fish oil, getting CoQ10 and Hawthorn at the right dose and standardized grade. Well, I'll show you how to do this practically. You can consider garlic supplementation. I personally think it's dangerous. More fruit and vegetables in their diet. Don't forget about mind-body techniques. Show them how to do it. Give them research or resources that they can access so they can do this effectively. And be cautious with THC use, especially in people with existing cardiovascular risk factors or previous history. The preceding recommendations can be used in conjunction with standard antihypertensive drugs. So this can be, even if they're on antihypertensive drugs, they can do this. And over time, often some of those drugs can be, the dosage can be reduced, or the drugs can be eliminated by their doctor if possible. So, these are valuable. So you saw these references throughout this presentation. Here are the actual citations. I put them right here for you to look at. Adëeva has some supplements that can help. So I made Cardio Essentials with CoQ10, standardized grade of Hawthorn and quercetin. Of course, Nature's Essential Oils has a high yield fish oil, flaxseed oil, and also borage seed oil. I love that combination. And the Adëeva all-in-one multivitamin can help them get calcium, magnesium, and other cardiovascular protective nutrients. So let's look at this. Here's Adëeva Cardio Essentials with 30 milligrams of CoQ10 per caplet, 37.5 milligrams of a standardized grade of Hawthorn, and 50 milligrams of quercetin. Quercetin is also very anti-inflammatory in the bloodstream. So because your CoQ10 is dropping off as you age, by age 45, everybody should be taking 1 capsule a day. By age 60, you should be taking 2 to 3 capsules a day. If you're on a statin drug, you should be taking 2 to 3 capsules a day. And if you have high blood pressure, according to the references that I showed you, you'd need 2 to 3 capsules twice a day, and you're getting that CoQ10 and Hawthorn that meets sort of the clinical studies that I showed you earlier. People with dilated cardiomyopathy, we've had patients that have had this, and 3 capsules twice a day has helped many of them. A lot of these people are young males between 20 and 60 years old that develop this. There's no real good medical answer. This product has helped a number of people with these cardiomyopathies. Just tuck that into your back pocket. But remember, because it contains Hawthorn, people on digitalis and digoxin cannot use this product. Nature's Essential Oils, 400 milligrams of borage, flaxseed, and a high-yield fish oil. Does all kinds of great things, but with respect to heart disease, it's helping to dilate arteries, decrease the stickiness of the blood, reducing elevated blood pressure, as we talked about, reducing blood vessel inflammation, all these things that you want to happen, and to improve that omega-6 to omega-3 ratio. And our high potency multivitamin, not only with 500 milligrams of calcium, 200 milligrams of magnesium, but also all these great antioxidants to decrease free radical damage in the vascular bed to help preserve vascular function. The B50 complex to keep homocysteine down, a major risk factor for cardiovascular disease. And also vitamin D has cardiovascular preventive effects. So 2 caplets twice a day. So this combination of Cardio Essentials with Nature's Essential Oils and our high potency multi covers a lot of territory. And then you make the dietary changes that we talked about and put in the exercise and the mind-body work. You've got a comprehensive non-pharmacological approach to this thing that's complementary to low blood pressure management. So that's our multivitamin. I've shown this to you before, that has all the B50 complex and the antioxidants, the 500 milligrams of calcium, zinc, everything that you need from A to zinc, the lutein for your eyes, lycopene for the prostate and breast tissue and cervix. It's all there. So that brings us to the end of this discussion. Managing, getting blood pressure back on your radar and knowing the blood pressure of each one of your patients. I can't emphasize how important a measure it is to preserving people's lives. So we have the power to keep those procedures as part of our daily routine and to coach people a little bit in this area. I think they'll be very grateful to you if you do that, and it can make a very, very significant difference. So I want to thank you for attending today. I really do appreciate it, and I hope to see you again